What's going on, everybody, and welcome back. This is a little special bonus, if you will. This is part of our Clin Ed series right now that we're running through the Level Up podcast. But we're going to be doing this as a webinar that we're going to be releasing to the public because I just think that this topic is so important, and it's been really in line with a lot of the stuff we've been talking about and our core values with Level Up and CALU. And what we're going to be doing today is talking about navigating uncertainty and cultivating humility, and how embracing the gray can really improve our clinical confidence and our clinical outcomes. So I'm really excited because I also feel like embracing uncertainty and clinical uncertainty is such a buzzword in our profession. And so I'm excited to give it some more context and some more examples, and most importantly, help you all feel better prepared to really embrace this and turn it into an asset in the clinic, because I really do think that this is one of the biggest opportunities we have to really empower our clients and improve our confidence and communication skills. So let's get into it. Quickly, the learning objectives are really to A, appreciate the inherent uncertainty embedded within clinical care. B, to understand why embracing uncertainty allows for more authentic communication skills and clinical confidence. And C, to explore how to cultivate humility and why this is critical for doctor-patient relationships and meaningful professional development. So for those of you out there listening on podcasts, you can't see, but it's the Toy Story meme with Buzz Lightyear pointing to Woody, and it's captioned uncertainty everywhere. And basically, this is just setting the stage. Again, it's spoken about so much, but it is true. And we're going to see as this presentation goes on that as you begin to actually practice in the clinic, so many of the things that you were once so confident in at one time or another is going to be challenged. And you're going to maybe learn that there was a better way to do things, or perhaps that you might have been wrong on certain things that you felt very confident in. And again, depends on how you look at this, but it's really not a bad thing. It's actually can be a really good thing. And again, it depends on how you perceive it. But just in terms of setting the stage and embracing the fact that this is a reality of clinical practice, it's very rare when you have like a super textbook thing happen. Not just that, but even just, again, with your knowledge base, that's going to get challenged as you continue to grow if you're committed to best practice. And so, again, for those listening, we're looking at the rabbit or duck illusion now on this next slide, which is a famous kind of illusion. I've heard Scott Morrison talk about it, but it's also in Thomas Kuhn's Structures of Scientific Revolution. And he's a famous philosopher of science. I would highly recommend that book. It was really good. But basically what he talks about with this is we only find what we look for, and we only look for what we know. And so what this really means to me when we talk about embracing uncertainty is that a lot of times, like let's say in school, we're trained in a very myopic lens, let's say a very biomedical lens, and let's call that the duck, right? So let's say we're trained to see the duck. And so if that's what you're trained to see, that's what you're going to be looking for, and that's what you're going to see, and that's what you're going to find. And it's really the same thing about when you graduate and you might be really attracted to like the certainty of a system. So let's say you dive deep into McKinsey. If that's the lens in which you look at rehab, that's how you're going to see it. You're going to find those problems. And if we go to the toolbox analogy, if you're like, I'm going to take my dry needling course as the first thing I do, you're probably going to find a lot of trigger points, quote unquote. You're probably going to find a lot of tight muscles and people that would benefit from it. And so I think first and foremost, it's just so important to appreciate that we just simply don't know what we don't know. And oftentimes there's probably something out there that can broaden our lens a little bit and maybe give us a little bit more pause when we're reflecting on our confidence levels with certain things, right? Because I know for me, when I graduated, I was very confident in my biomedical knowledge base. And again, not that that's inherently a bad thing, but when we really look at the totality of evidence, maybe my confidence and certainty on some of those things shouldn't be so much. And when you can actually broaden your lens and be able to appreciate multiple perspectives, it's going to give you a much stronger ability to communicate some of that quote unquote uncertainty. So this is a paper that gets thrown around a lot, but Tolerating Uncertainty, the Next Medical Revolution. This is a part of our was called Level Up Mentorship, now the CALU Foundations, drop in August, let's go. But this is a required reading for us. It's 2 pages, it's a no-brainer, it's so good. But we love this quote. Our quest for certainty is central to human psychology. However, it both guides and misguides us. So what do we mean by that? You know, and again, like it's so important to understand, like all of us, like we all are on a quest to want to like know more and be more certain. But I think taking that grain of salt and understanding how it can also misguide us is really, really powerful. So here's an example. This was shared from a colleague of mine, Jared Hall, who I'm sure many of you are familiar with. I hope. If not, you should definitely toss him a follow on Instagram. But basically, it's showing, for those of you listening, we're showing a picture of a radiograph of 2 knee joints. And basically the question is, which one of these knees is painful? And I think this is a great example of quote unquote uncertainty in clinical practice, because if you were to ask me in school, I would probably be really confident that the knee that had more degenerative changes or a narrower joint space likely is the one that's going to be more painful. However, when you do actually look at some of the research on this, you see that it's not always the case. There's people where they'll take radiographs of both knees and one might look quote unquote worse than the other, but it's the other one that hurts. So it's one of those, I think it's a great example that, gets us to pause and reflect on some of the confidence and assumptions that we make about these things. And a great example of embracing that uncertainty. Again, it doesn't mean that it's not something that we need to consider, but perhaps we shouldn't be so overly confident about it. And I'm attaching all of the research that we've cited in this at the end in the references, and we'll put this in the show notes as well for the podcast. If we go to another example, and we're going to be talking about a couple of examples here, so bear with me. But the scapula is another one that rocked my world. Coming out of school, I was super confident about scapular dyskinesia. And if you could find that on a postural assessment, odds are that's the shoulder that's bothering them, or that's the one that's painful. But again, when you actually look at some of the research on it, it's like literally a coin toss where there's not as strong of an association or correlation as we thought there was with identifying some of these postural abnormalities and linking that to shoulder pain, let's say. And again, asterisks. It doesn't mean that we shouldn't consider that. It just means that if that's the only lens at which we're looking at it, that's problematic, because it might not always be as important or valid as we once thought it was. So we're going to close this section with a beautiful quote from the Tolerating Uncertainty paper. Too often, we focus on transforming a patient's grayscale narrative into a black and white diagnosis that can be neatly categorized and labeled. The unintended consequence, an obsession with finding the right answer at the risk of oversimplifying the richly iterative and evolutionary nature of clinical reasoning, is the very antithesis of humanistic, individualized, patient-centered care. Whew, that is such a heater of a quote. And man, do I feel guilty as hell as a new clinician, feeling the pressure to give these like overly simplified narratives for what's going on based on my confidence levels and based on the expectations I felt I had on myself. But then having that realization of like, oh my God, like is like, A, are these assumptions I'm making even valid? And B, what are some of the consequences of this, right? How is this going to affect the human that I'm working with? Is this going to maybe give them some thoughts or beliefs about what's going on that might not be super helpful? And we'll talk about that a little bit in terms of why this stuff matters. But I just think this is a really, really powerful quote to share. So what are some other examples of clinical uncertainty? I'm not going to go too much into depth some of these, but here's a greatest hits, if you will, some of my favorites. So we know imaging and pain. The Brzezinski, I'm totally butchering the name. They've done a lot of research, and there's it's not absolute one way or the other, but there's a large body of research that shows us that imaging is not this one-to-one correlation with pain that we once thought it was. And so they've done a lot of spine studies, shoulder studies, knee studies, looking at images of symptomatic and asymptomatic cohorts, ages teens, 20s, 30s, 40s, 50s, 60s, 70s, and showing that as we age, there's a higher probability of what we would kind of call these base rates or base findings, where let's say we look at a cohort of 40-year-olds, and there's a fairly sizable percentage of people in that age bracket that might present with some quote unquote normal degenerative changes. And this doesn't necessarily mean that they're experiencing pain. And so again, when we go back to talking about the relevance of imaging or structural pathology, we have to understand that it certainly could be relevant, but in some cases, or in many cases, it might not be as relevant as we thought it was. So we'll move forward. Manual therapy, right? When I graduated, I was still very seduced by kind of the manual therapy culture that permeates so much of orthopedic physical therapy. And it was all kind of around this idea that we are kind of manipulating joints, we're breaking up tissues when we're doing our soft tissue work or Graston. And then when we look at a lot of the research on manual therapy, we understand that a lot of the specific effects that we thought we were doing aren't such. And again, this doesn't mean that it can't have some short-term improvements or have some relevance in clinical practice, but it's the high level of certainty in which I was utilizing manual therapy that really needed to be audited by a lot of the counter evidence that challenged, some of the proposed mechanisms. And so the paper by Bialowski from 2018 is a phenomenal one. I have all of these attached for those listening. And then we talk about the kinesiopathological model of pain and movement. All right. And so this was my bread and butter as a new clinician was, let's give an example of like core stability. So you have pain because you can't stabilize your low back. And again, there might be some research that shows it might have a small effect size, but we have to also ask questions of like, is this exact mechanism that we're proposing the reason people are getting better, or are there other things that might be influencing the reason they're getting better? And not only that, there's also a multitude of other things that help people improve with low back pain. And yeah, so core stability and more of this kinesiopathological model of pain and movement is something I'm really passionate about, because I think it makes a lot of sense from a very superficial perspective. Like, oh, if you go into knee valgus, you're going to create more stress on the medial patellofemoral joint, and then you're going to get more pain. But that is not necessarily true. And we have a large body of evidence to kind of refute some of that. So again, it doesn't mean that it's not worth considering, but the certainty at which we talk about it in the profession is honestly a little bit alarming to me, given the fact that it doesn't really hold up in logic court, if I'm being honest. If we move forward, we start to understand a lot more about placebo effects and meaning response. And this kind of gives way to helping us better understand a lot of the non-specific effects of why people get better in clinical practice. And so that might mean why, if let's say you have a kinesiopathological approach to helping someone improve their low back pain and use a core stability paradigm, they might end up getting better. But again, what was their expectation they were going to be getting better? What was their relationship with you? How confident were they in you? Were they highly recommended to go see you? There's a lot of contextual factors that we need to consider. And then, not to go too crazy, but then even with placebo effects within themselves, there's a lot of evidence and research to challenge how actually valid some of these placebo effects are. And if they're not just things like natural history. So that's just another example of a time where I felt very confident in challenging and embracing some of these non-specific effects and placebo effects, but then having more research come out to challenge that again. And it's just a nonstop cycle, and it's going to keep happening. Another one that rocked my world is pain neuroscience education efficacy. And, you know, we have an amazing podcast interview with Adrian Traeger, one of the lead authors in this epic RCT that shook the industry. But it basically showed that pain neuroscience education in acute low back pain was not necessarily any more effective than sham education for outcomes. And I think that was a really powerful moment, because I think it just humbled a lot of us to say, like, look, like, obviously I'm a huge pain nerd, and I think it's super important to understand, but I think there's also needs to be this auditing and humility with the application of it and the relevance of it, and how we get that into our clinical practice. And then lastly, like Paul Salam, Jeremy Lewis, they've been very vocal about special tests. And I'm sure this is not new to you. This is something that I think is harped on pretty good and for good reason. But like in school, I learned a jillion special tests. And we'll talk about this when we get into the shoulder in this presentation. But again, it's just a great example of, you know, I go through and let's say I pinpoint that it's, a primary impingement, primary external impingement, and I suspect the supraspinatus is involved. Does that really change the way I'm going to manage things? In terms of helping that person, I would argue likely not. But again, they might have a time and place, but there needs to be an asterisk around it. So I apologize for going through that rant, but I attached all of these papers. They're some of my favorites. I would highly recommend you read through them. Don't appeal to my authority. Get your own interpretation of them, and let's chat, because I find this stuff super fascinating. And so after some of these things, you can find yourself asking, does anything I know even matter? Is everything I learned in school a lie? And it's hard not to feel that way. And while this all might come across as extremely nihilistic, the things you learn in school are still extremely important, and your knowledge base does matter. And it's just like, and we're going to talk about this, but when you can really cultivate that authentic humility and a really increase the depth or breadth of your knowledge and have these multiple lenses, it's going to afford you the opportunity to communicate about these things with so much more confidence and conviction, and really improve your patient outcomes. But you need that knowledge base from school. It's so important. So we're going to talk about a clinical example, posture and shoulder pain. So let's say you have an individual coming in to seek your care, dealing with some anterior shoulder pain. Upon your subjective exam, you don't find any clear-cut mechanism of injury that explains their pain. Upon your objective exam, you find that they have forward head posture, protracted and weak scapular muscles, and you begin to formulate the case in your head that this person has shoulder pain because of these factors, and you diagnose them with subacromial impingement syndrome, likely secondary to upper cross syndrome, the double syndromes. Let's go. So my question to you all is, how do we start to look at the bigger picture and understand the multitude of other factors that could be influencing this individual's pain experience? Or said differently, how do we begin to communicate uncertainty? Water break. So we're going to go back to that case study, and we're going to start with answering that question of how do we start to communicate uncertainty? Well, I'll tell you what it starts with. It starts with a big fat serving of humble pie. This is something that we advocate for, and we beat the drum. I'm sure many of you have heard it, but embracing that humility, having role models and mentors demonstrate that can be one of the most empowering and influential things for your clinical practice. And that's what I had. I was super lucky to seek out mentors who really embodied this. But I'll be honest with you, and I loved my professors at school. I had a great experience, but there was definitely a lot of certainty that came along with the knowledge that I was learning in school. So I didn't necessarily get exposed to some of the practical skepticism and the humility in that way. And I think it's just so important for clinicians to embrace this early and often, because it's going to make you so much more agile as you're growing and developing. And it's going to make the fall, like for me, the fall for me from like the peak of Mount Stupid to the valley of despair was brutal because it was such an incongruency for me, that it was really, really tough. But if we can start to embrace this humble pie, it's really going to help accelerate that, I think, and make it easier for folks. Another thing, right, is this notion of really embracing being wrong. This is so important. It sounds so obvious, right? But I think as clinicians and in the medical profession, I think our culture is still very much about like having the answers and having certainty. And I think this culture of humility doesn't really exist, or isn't the dominating culture in my reflection of what's going on based on my interactions in school and just at the industry at large. But I really do believe that if we can learn to embrace being wrong, right? It doesn't mean that I'm always going out seeking, trying to be wrong all the time, but more so that I'm always open to being flexible with my beliefs when there's better information out there that might challenge me or might give me a better line of reasoning. And we need to be okay with that. But the reality is, and this is what Catherine Schulz talks about in Being Wrong, which highly, 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 highly recommend reading that book. But it's like, being wrong sometimes like can really shatter our sense of self, because oftentimes some of these core beliefs are so entwined with our identities. And so being wrong can be brutal. Like I remember graduating from school, and when I was starting to confront some of the evidence challenging me on like core stability, for example, I was shook. Like and that might not even be the best word to describe it. I was angry. I was pissed. I would get upset with people that were challenging sort of that narrative, and like they weren't challenging me, but I took it as that because I identified with that narrative. That was a part of my identity, right? And so I understand it's really hard for people, but if we can start to advocate for this earlier, again, it's like a skill, and the more we do it, the better we get at it, right? And there's been so many evolutions throughout my 7.5 years of clinical practice that it's gotten easier every time. It's never fully easy, but like I've learned to truly embrace this as an opportunity to be better, and not so much as, oh my God, look how wrong I was, right? So how are we perceiving that? So how do we start to cultivate this authentic humility? For many of you, hopefully, if you're familiar with the Level Up Initiative, one of the things that we began super early on was the Challenge Yourself campaign. And I really want to bring that back. But I think we had over 50 submissions from our community, but it's really incredible. Basically, it's just an opportunity to really dig deep and reflect on a time in your life that was super challenging, that you were able to take ownership for that and embrace it and move forward in a positive and constructive way. And so I would recommend we'll share some of these on our story because they're phenomenal to go look at. But ultimately, what we're getting at with that is that the power to transform lies within you. It has to start with you being able to look in the mirror, being able to justify, why you're doing what you're doing. And if you can't really justify that, then being okay with changing your mind and doing better. But if you don't have that level of humility, if you don't have that level of ownership, that's going to stifle any real meaningful growth. The next way we do it is with our critical thinking hat. So for those of you that are familiar with Level Up, you know that that's the second module in the free mentorship that we do that will be part of CALU Foundations. But we are big on, when I graduated from PT school, I was very seduced into wanting to, what system do I need to take? Do I need to take SFMA? Do I need to take PRI? Do I need to take McKenzie? And again, don't strawman me just yet, because I think there's a time and place for these things. And I'm totally at peace with people going in and diving into some of these systems. They probably have some good things to offer. I think the problem is, though, that if that's the first thing that you do out of school, you're going from like a very myopic biomedical education to now a very myopic system. And you're going to fall prey to that rabbit or duck problem again. And So what we advocate for is that first year of practice, I mean, really third year of DPT school or MSK school and first year of clinical practice, like that is where you build a beastly foundation to think critically first. And the way, and we'll talk about ways you can do that, but if you can truly embrace cultivating strong critical thinking skills or your critical thinking hat, that is going to set you up for so much success because it's going to inform some incredible communication skills. And it's going to give you this ability to be so flexible and agile that as you continue on with your professional development, you're going to be able to go and take some of these different courses or systems, but instead of like drinking it up and taking it all at face value, you're going to be able to say, okay, cool. Like I can understand some of the value in this without, necessarily having to feel like you're all in on this system. And it just is like MSK rehab, when it comes down to it, communication, exercise prescription, these things are so important for what we're doing, and our ability to think critically directly impacts both of those things. And that's why we're so big on it. I think one of the ways that you do that is by reflecting, right? And when actually, I'm not gonna spoil it yet. We'll talk about ways to do it. So how do we start to cultivate authentic humility? It's this willingness to be wrong, combined with our ability to truly reflect and take ownership for that, combined with true critical thinking. And when we can do that, we really start to cultivate this authentic humility. And when we have this authentic humility, that's when we start to have increased clinical confidence and communication skills. And so when I talk about embracing uncertainty as a clinical superpower, I mean it, because like if you know your shit and you're able to understand the different perspectives and sides to things, that's going to allow you to finesse so many conversations with people that might be at different places on their journey and understand where they're coming from, but know how to navigate it in a way that still is super confident, but isn't necessarily like, 100, like giving these 100% certain overly simplified narratives. So the other reason why authentic humility is so important is because authentic humility breeds trust. And as many of you have heard me say time and time again, one of my favorite quotes from Nicole Piemonte, trust is requisite for healing. And this trust has its foundation in something more than a technical skill. So when we can really embrace this humility, this critical thinking, this ownership, it helps us create trust with our patients because we're able to be transparent, we're able to be confident, and we're able to navigate these conversations in a really empowering way. And that for me has been one of the most transformative things for my clinical relationships and meaningful outcomes, frankly. Whew, okay, we're doing it. So what does this all look like in action, and how does one get started? So step one, and if you haven't, go back and listen to the last podcast we did on establishing a rock solid orthopedic foundation. That's a prerequisite. It's like you need to, like, if you're going to challenge a biomedical model, you need to know it. You need to know your orthopedic knowledge base really, really well, because it's a really important lens to inform our clinical practice. However, again, that can't be the only lens. We need to broaden. We need to understand the different perspectives so that we can, navigate it with more finesse. So then that's really the step two, which is zooming out, basically. We need to truly adopt a framework that recognizes the multifactorial nature of MSK pain. We need to adopt a framework that recognizes things like socioeconomic factors, cultural factors, the lived experience, all of the counter evidence in the biomechanical research and orthopedic research. And so, yes, it's embracing that BPS life, but it's also embracing a lot of the counter evidence within the biomedical type of research. And again, like when we talk about embracing this BPS lens, it's not the misappropriation of it where it's like just this like, oh, we need to be able to pinpoint, like sometimes the psychosocial stuff matters, sometimes it doesn't. It's like, that's not necessarily fair or true. It just is something that needs to be embraced into our holistic thought process. of how we're kind of zooming in and out when we're working with clients. Step 3, this is the most important one. You need to wrestle with different perspectives. You need to reflect often. And here's a good way to do that. You need to have a personal learning network or a challenge network. When I read Think Again by Adam Grant, which was kind of like a nice addition to Being Wrong by Catherine Schulz, he harps on this all day long, which is like, you need to surround yourself with people who give a shit and with people that are going to challenge you in a constructive way to be better. And that's why I'm so proud of what we've created with the CALU community, because it is a robust, amazing network with some badass providers that are all about that life. And so if you're looking for a place to start and you're not in our free Facebook group, that would be an amazing place, because you will get exposed to different perspectives. It will cause you to reflect, and you'll be just surrounded by some amazing minds. But even if not with us, make sure that you're surrounded by some sort of personal learning network or challenge network that's really going to help you grow and wrestle with some of these different perspectives and better understand your own. Okay, so now we're going to get into a practical example of embracing uncertainty. And so we're talking about the diagnostic paradox. So for those that are unfamiliar, basically the diagnostic paradox is that we understand that patients want a clear diagnosis. If we look at a lot of the qualitative research on what patients want and their expectations, we understand that they want a clear understanding of what's going on. Pretty reasonable. And the paradox is that there's this feeling that unless we provide an exact structural pathology, then we're not communicating a clear diagnosis. But in the face of all of the evidence we know about how some of these exact structural things correlate, we know that that wouldn't be fully honest. So that puts clinicians in a sticky position, because we want to provide confidence, we want to provide a clear diagnosis, but if we're being honest with the evidence, how do we communicate this how do we communicate this uncertainty in a clear and empowering way? And this is where that critical thinking and authentic humility comes back in. So if we're able to think critically about the evidence, we understand that bearing any acute traumas with a clear-cut mechanism of injury, like a fracture or ACL tear, it's nearly impossible to be fully certain about an exact tissue diagnosis. Yet, if we zoom out, this doesn't mean we can't be communicating about and validating possible MSK contributors while still acknowledging the ambiguity of it and still communicating a clear diagnosis and prognosis more through this BPS lens. We're going to give 2 examples of that. So let's revisit that anterior shoulder pain. So first off, what are some other questions that we can even ask for this person when they're coming in, besides for just pinpointing on, some of the postural findings that we had? And to follow that up, are there any other potential contributing factors to consider? So we're not going to spend too much time here, because this was meant for more of like a group discussion based thing. But essentially what I'm getting at here is anytime someone's coming in with insidious onset, really want to look to ask some more questions about like their activity history, exercise history, occupational demands, patterns of stress, both physical and, emotional or psychological or mental, whatever. I want to understand all of that stuff, because perhaps there might be some little clues that have emerged in terms of, like maybe they started a new program where they're like, yeah, I started this program, I'm doing 100 push-ups a day. And you're like, cool, what was your base of push-ups before that? And they're like, none. And you're like, all right, well, I don't want to be overly certain about it, but maybe that's a little more relevant to their shoulder pain than their forward head posture, as an example, right? So it's things like that. And so how do we communicate a realistic yet empowering prognosis to this individual while still acknowledging the uncertainty of the situation? So we're not gonna watch this video because the audio is gonna come out poorly, but basically Steph and I did a skit where she was a patient that was really, really, really hung up on the narrative she was told by past doctors, past physios, that she had shoulder impingement, and this was due to this was secondary from her scapular dyskinesia. She had a winging scapula, and she was told that was why she ended up having shoulder impingement. And she kept pressing me about what's going on. And so I might communicate to Steph in this example where let's say there was some sort of trend in her history taking where she had some sort of spike in loading with certain exercises that involve a lot of pressing, both forward and overhead. And I might say, look, Steph, the good news is that we were able to go through a pretty thorough exam today, and I think rule out anything super duper significant. It does seem like there's some parts of the front of the shoulder that are probably a little bit irritated right now, but based on what you told me about kind of getting into that new workout routine and having a decent amount of volume that you haven't really been used to, that kind of makes sense to me as something that could potentially be something that might have triggered this to begin. But either way, like even if that isn't exactly what's going on, either way, we've been able to identify a few key things that you currently can do and that you're looking to get to be doing. And so we have a starting point, and there's a lot of things that you can do. And so there's going to be a lot of options for us to get you back to, working out or doing the things that you want to do. Okay. And then Steph pushes back and she's like, yeah, no. But what about my scapular dyskinesis, or what about my winging? And that's where I might say, look, Steph, like, honestly, yes, like on that side, there's definitely a little bit of some scapular winging going on. But if it's all right with you, I'd like to share sort of my perspective on where that weighs in on this. And, that's where I would say something along the lines of, look, the exercises we're going to be doing are ultimately going to be kind of embracing some of that anyway. But I think the biggest thing to understand is that a lot of what we've understood about that being directly related to shoulder pain doesn't necessarily hold up as much as we once thought it was. And what I mean by that is there's actually a number of studies that demonstrate people that have some of these same findings, winging, but don't have any sort of issues associated with their shoulder. So it could be relevant, but in this case, I think, again, like it's going to be touched on anyway with some of the exercises that we're doing. But I think there's other factors that might be a little bit more important to look at, like some of the load management and volume and exercise selection that you're doing in your workouts. And then to beat it a little bit further, she's like, okay, but what about like what shoulder? Because she was like, what structures in my shoulder are getting irritated though? Because I was told I have impingement, and I'm pretty concerned based on what I was told. And so if they're asking that, that's where you can be like, look, it would be hard for me to tell you exactly the structure that might be irritated in this case. But if you really wanted to understand, there's a few structures that we know pass through this space in your shoulder, the supraspinatus, the long head of the biceps tendon, for example. So perhaps it could be one of those. But ultimately, and again, this is the big thing I really want you to understand, is that even if it were one or the other or neither, it wouldn't radically change the way we're going to manage this. Because again, we understand that the overall prognosis for anterior shoulder pain is pretty positive. And we've been able to identify a ton of things that you're already able to do. And so that's going to inform our starting point. And I think we're going to be able to really see some good improvements as we stick to this plan. So hopefully by that time they're about it. But just wanted to give an example of ways that, you're going to get pushed on by patients where they're pushing you and kind of pressing on you for like, I want to know the certain things, and just having that ability to roll with it and navigate it and still be confident. Like I'm confident in what I just told Steph, but I'm not like, it's a weird thing, right? It's a different type of confidence. It's confidence in the uncertainty of it and confidence with a plan to move forward, but it's not confidence with this like perfectly myopic explanation of what's going on. So this is not to toot my own horn. This is just to give a practical example of like, I think sometimes we think about like, can embracing uncertainty really be a successful, like, can that give good clinical experiences? And I think 100% it does for so many of the things we spoke about. But here's a review from a patient I worked with some ambiguous kind of anterior hip pain. said, I had the chance of working with Zach over the last 6 weeks, and I'm in awe of his knowledge and enthusiasm. He recognized the ambiguity of my injury and worked with me to develop a cohesive and approachable plan. This guy got back to running ultra marathons, but he was, diagnosed with certainty of hip flexor tendonitis or, FAI, or labral tear, things like that. And ultimately, like, there wasn't anything in his testing that was like a slam dunk for any of those things, but we were able to really rally behind the fact that we were able to rule out anything super serious. We were able to look at his training program. We were able to look at the things he could do, which was a lot. And we were able to provide some really good graded exposure to the demands of his task and get him kicking butt again. And that's why, we're so big on this. And I really think can be your biggest weapon in clinical practice when you learn how to really broaden your lens, appreciate the differing perspectives. It's going to make you a much better clinician, much better communicator. And so I hope that was helpful. So in closing, remember, you do the best you can until you know better. And then when you know better, do better. You can't beat yourself up for being wrong ever. It's literally how you get better. So surround yourself with people who embody that. Reflect often and focus on cultivating excellent critical thinking skills, right? And the way you do that is by reflecting. You need to reflect in order to improve, right? This increased reflection and openness to being wrong and critical thinking skills is how we develop that authentic humility. And that authentic humility is how we can really improve our increased clinical confidence, communication skills, and thus trust. So always end on my corny note. Everyone out there listening, like, again, our mission is to make an impact. And part of that is by investing in all of you listening and like lead by example, shift the culture, be the change our healthcare needs, because the way you shift the culture is by leadership. And leadership is just simply your actions. It's your behaviors. It's the values you embody. And that is my ask for all of you, is just to embody these values that we're talking about and be the change that healthcare needs so that we can collectively make a shift, because we are, but there's still a lot of work that needs to get done. And our profession kind of depends on it. And more importantly, our patients depend on it, right? Because that's what it's all about, providing the best possible care for our patients. So thank you all very much for listening. I hope that it was helpful. And lastly, if you're not already involved, the CALU community is phenomenal. We've like clinical athlete level up coming together. We do a free monthly journal club. We do a free case study every other month. There's tons of great resources shared in there, tons of great networking. We have some different starter packs. It's just good vibes. It's good energy, and it's surrounding yourself with, honestly, one of the best challenge networks or personal learning networks in the game. So you can join there. Just search CALU Community on Facebook. And I really hope that this webinar, podcast episode, wherever you're digesting this, was helpful. Always open for conversations, always open for feedback. Please, please, please hit me up and let's chat. And here's all the references. I will attach them all on the webinar and in the podcast notes. So, all right, everyone, have a great rest of your day, night, morning, wherever you are at in the world listening to this.